Hello, and welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thanks for joining us. I'm Alan Card. I'm a research associate with the Center for Health Design, and I'll be your host today. I'd now like to introduce you to the authors of the article we're going to be discussing, Jennifer DuBose and Larissa McAllister. Jennifer DuBose is the Associate Director of the Georgia Tech SimTegrate Design Lab, an expert in evidence-based design, sustainability, and carbon accounting. She's a principal research associate at Georgia Tech. She has helped lead the creation of the SimTegrate Design Lab, a multidisciplinary lab focused on using research and simulation to bring about value through integrated, human-centered design of healthcare settings, health products, and care processes and cultures. Larissa McAllister is a researcher and architect who is blending her experience and expertise in healthcare to pioneer a unique approach to design and healthcare industry in the world. And Dr. McAllister has dedicated herself to guiding organizations to the next level of integrated performance by systematically aligning operational processes and the environment to improve an organization's culture, business, performance, and user experience. Using evidence-based design and other research, she has constructed a new approach to enhance the environment as a tool for its occupants. She speaks nationally to help bring about transformative change that benefits stakeholders, patients, community, and the environment. Dr. McAllister is the founder of Envia, an evidence-based consulting firm that uses people-centered approach that is both multidimensional and multidisciplinary. Envia creates healthcare environments where people thrive while helping providers effectively accomplish their mission. Dr. McAllister and Envia work to integrate people, technology, systems, and space, ensuring that healthcare environments are driven by health and care. I do also want to mention two authors presenting today, Katara Hadi, design analyst at HDR, and Bonnie Sakalaris, Vice President, Optimal Healing Environments at Thought Leadership and Innovation Foundation. Thank you very much to the authors for joining today. We're hosting this event to identify the everyday practical applications of research findings in a published article. Today's article, Exploring the Concept of Healing Spaces from the Health Environments Research and Design Journal. On today's call, we will have an active discussion about different key factors in your study. And now, without further ado, I will turn it over to the authors. Thank you.
Thank you, Alan. This is Larissa McAllister, and again, thank you for that very glowing introduction. I wanted to share with you our paper that we published many years ago. The literature review paper was envisioned and funded through the Samueli Institute. The Samueli Institute worked for 15 years to advance the science of healing worldwide by applying the academic rigor to research on healing, well-being, and resilience, translating evidence into action through the U.S. military, large-scale health systems, and fostering wellness through self-care to create a flourishing society. This work, in particular, was supported by the U.S. Army Medical Research and Material Command under an award number W81XWH07. And the views and opinions of these findings by the authors and are constructed as an official document of Army position, policy, and decision, unless certified by other documentation. Through the systematic research, the Samueli Institute, a holistic framework was developed, which you see here on this slide, to better define the domains of health creation. This holistic framework is the ideal and optimal patient experience for health. So in this framework, you'll see that from the reading from left to right, the internal domain is for personal well-being and to really help oneself and understand oneself's need for healing. The interpersonal, which is the second bubble domain, is the social relationships that we have in everyday life with individuals as well as organizations. The third bubble and domain is identified as behavioral. So these are these life choices and activities that we have and engage individually as we as well as collaborative medicine and integrative medicine. And then the final domain is external. So this is all of what is built in the environment, both outside and inside, including sustainability and ecological resilience. So this framework was used in understanding of what is defined as an optimal healing environment. And the intent behind this paper was to more fully understand what does it mean to have a healing space. The organization, the Samuel Institute, had been working for many years and had used an extensive concept analysis process to identify the definition of healing, because in order to study and advance the science of healing, we first had to have a universal definition. This universal definition and research was conducted by Dr. First and published in the Global Advances of Health and Medicine in 2015 to define healing. While it's hard to be measured when a person is fully healed, the work of healing is a process and experience. And this definition, as identified on the screen and the slide now, was really the culmination of that work and really helping to more fully understand what healing meant. This definition provided a universal understanding, and now we wanted to define what it meant to make a healing. With that as a springboard, as the field of evidence-based design was advancing, the Institute was interested in that research to better understand, again, this healing space. To the excellent work and research that was conducted in 2008 by Georgia Tech and Texas A&M, as well as the Center for Health Design, and two of the research literature for evidence-based design. This leading paper and analysis would provide the framework for this exploration of what is a healing space. Jennifer DuBose would lead that rigorous exploration in coming through the research to uncover the working definition of healing. So, Jennifer.
Hi. So I'm going to go into some of the details now because that's my role, and hopefully you can hear me well. It sounds like we're still breaking up a little bit. So I'll speak slowly, or try to speak more slowly than normal. So one of the reasons why we were brought into this project and why we thought we could succeed in this kind of nebulous task is that we had worked on the 2009 review that was published in Heard, where this table came from that you see on the slide now. So we thought we could use a very similar approach, right? We could set up a structured research, search query, look for discrete studies, and then we could report on what we found. So in evidence-based design, that we published previously, we were able to associate specific environmental interventions, like you see along the top row there, like single bed rooms or access to daylight, acuity adaptable rooms, and we could relate those to specific healthcare outcomes, like reducing hospital-acquired infections or falls, reduced pain, stress. So this is how we this approach before, and we thought we'll apply the same process to healing. We found that was different, that it wasn't quite so amenable to that. And when we did this for healing, what we found is that really people were using the word healing when they should have just been using outcomes or physiological health. So we had to kind of take a step backwards and figure out what exactly is healing so that we make sure we're looking for the right materials. So what we found in that process was that really we could talk about healing as 4 different constructs, and that was really the pieces that were missing, that weren't reported previously in our literature review, and that were necessary to help the field understand healing. So those 4 constructs are psychological aspects, which have to do with emotions and your ability to control your emotions, self-efficacy, the sense of control with the world and situations, social issues, which is relating to family members and between patients and caregivers, and then functional, which is actually the concrete part, right, of just being able to do the activities of daily living. Are you able to do that? So the big distinction here that I think is really important is to understand is that this is not the same as curing as we are typically doing and trying to accomplish in our healthcare environments, right? This is a slightly different process, healing. So I'm going to explore the difference just a little bit more. A few concept maps or cause chains. So in traditional evidence-based design research, a lot of things we had previously reported on, you have a really direct causal link, right? So you can say that noise and light have a direct impact on sleep, and generally a negative impact, sleep disruption, and that sleep disruption has a negative impact on physical recovery. So that's a pretty easy to understand causal chain. There's also less direct causal links in evidence-based design. Say research that has shown that having a family zone in a patient room can improve or influence visitation by the family, and that can speed psychological recovery. We use dotted lines here because it's not as direct of a relationship, right? We know that the family zone doesn't cause family members to visit, but it allows that to happen, and it makes it more likely to happen. And we know that, again, family visiting doesn't always cause psychological recovery, but it can. So this is more the picture that we found when we started looking into healing and the research around healing. Much more complicated story to tell here. We start with the outcome being healing on the far right, health or being cured. We can look at in the middle, the immediate outcomes are those those constructs of healing, right? Psychology, self-efficacy, social, and functional. And the environmental conditions that we found to be associated with those, to affect those in the literature, are things like home environment, or a home-like environment, access to nature, control of noise, barrier-free environments, and room layout. But it's even more complicated because in the case of healing, there's some really significant mediators between impacts, so those influences aren't even direct. So the first one really that's important for healing is the mental state of the patient. A lot of this is dependent on the mental state of the patient. You still there? And so even if you have a home-like environment or light or access to nature, you don't necessarily have those intermediate outcomes because it all depends on the readiness of the patient and the willingness, the receptivity of the patient to be healed and to respond to them. But then there's also the impact of time is the last mediator that's really important, and that's that healing actually takes longer in some cases than curing. And so healing may not always happen right there moment in the healthcare, in the surgical suite or in the hospital room. But healing might initiate there, and then the process carries on. So it makes it a little bit less tidy to study than research that's about your immediate perceived pain and the view out your window. So now I'm going to show you some of the things that we found in our research. So when we started using those terms and looking at the research, we had more success than when we had just looked at healing. So we put in those 4 constructs. And here's what we found. We found, in fact, that there's a large bucket of environmental conditions on the far left that influence this even larger immediate outcomes, which are really those components of healing. So we might not see that music causes healing, but music might impact on one of these immediate outcomes, which then in the long term has an impact on healing. So this is what we found, and this is information straight from the paper. But what we did, where I think we added value, right, is how to understand that. So how do we make sense of that, those 2 large buckets that are related to one? So the piece that's most useful to us to look at, and I think for the audience on the call today, is that is looking at those architectural variables. So what are the design strategies and the parts of the environment that have some influence over healing, even indirectly or via other moderators and mediators? So we found, again, lots of specific variables. We group those to make it a little bit easier to digest into these 6 categories of home-like environment, air control, access to nature, which is both indoor plants and views out the window, control of noise, barrier-free environments, which gets at your ability to navigate a space, and then the room layout being a category that encompasses single bedrooms versus multi-bedrooms. So those were the architectural variables that we found referenced in the literature. And then these are the healing outcomes that we found. And again, we were able to take that large bucket of outcomes and put that into these larger categories that were those 4 constructs we had identified of self-efficacy, psychological, social, and functional. Self-efficacy, again, is going to be your control, autonomy, and independence. Psychological is more the anxiety, pain, stress, and depression. Social is that sense of isolation that you want to avoid having, and relationship with caregivers. And functional is they get the more concrete and easier to understand ability to do your activities of daily living. So it's not, are you healed back to where you were before, but are you able to accomplish what you want to accomplish? And this is the map that we put in the paper. So hopefully it's better in the paper than you can on the slides here, but I just put it included in the slides to show you that we tried to, again, process this information and make it digest by associating those categories. So on the left are the architectural variables grouped into six buckets, and then associating those with the specific healing outcomes that we saw. So what you can see here is that, it's not a correlation. There's not a one-to-one, one bucket to, or one variable to one outcome, but there's multi to multi. So it's a complicated relationship, but we also see there's lots of opportunities to affect lots of different parts of healing with specific with specific design strategies. And this is just a close-up, zoom in to show you how that worked. We actually had developed a paper, but we had, for some of our background research for the Samueli Institute, had associated specific variables with specific lines. So, when we make a connection between two boxes, there's an actual article that can go back and be referenced to that. So that's what we found. What we were able to do and conclude is we were able to come up with a definition of healing spaces. So, and this builds on the Samueli Institute definition of healing, right? So healing spaces evoke a sense of cohesion of mind, body, and spirit. So we're getting out of just being about the body. And they support healing intention and foster healing relationships. What we were not able to do is find specific metrics and measures that can tell you whether or not a space has successfully been a healing space, has it successfully acted as a healing space, or have you designed it to be as healing as possible? So we weren't able to come up with those metrics, but I think that we were able to provide value to the field, and by putting things in these categories and giving you the design strategies and kind of showing how those influence the different aspects of healing. And I'm going to turn it back to Larissa to talk about some of those more specific design implications, how architects can apply this information. And having a good discussion with you all momentarily.
Great. Thanks, Larissa. Jennifer. Excellent work. Thank you. So as you can see here, the diagram again with the 4 domains, as Jennifer went through the information and the research that was conducted through this process, we really identified that both internal, while the internal really related to the psychological domain and bucket that Jennifer and the team, when we reviewed this information, that it did actually work with the optimal healing environments framework that I initially mentioned. So the internal or psychological was supportive of a home-like environment, spiritual intervention, natural light, music, and sensory room. So again, an architectural opportunity here is, again, just meeting the person and their needs to provide those sensory rooms when agitation is happening, to allow that person to kind of get things back together for themselves. Again, looking specifically at that person and their internal struggles. This is very much a part of the behavioral health environment, so lots of learnings and opportunities within that domain. The next domain, in regards to the interpersonal, which is really more the social relationship, and that interpersonal, those are those social relationships with caregivers and those providing opportunities for more increased cadence of the cadence of visits and interfaces with your caregiver, as well as providing space within your environment to allow for visitors to come to your home or come into a patient room. So those encouraging those social and interpersonal relationships as a key component in architectural opportunity. The next domain in the behavioral side is the self-efficacy or self-control, the ability to control that environment, whether that is choosing their own artwork or music that's being played in the room, as well as providing a sense of dignity for that patient or their loved one, and also allowing them to have their own choices or daily activities, continue their daily life and those daily activities and behaviors. The final is the functional or external. The functional movement of a person through the environment, so whether or not, again, this is that barrier-free opportunity to look at the opportunities to provide high mobility for these patients and folks, to have their, again, activities of daily living, as well as making simple decisions of an elevated toilet seat for the ability to ambulate and use the restroom as they need, as well as choosing flooring surfaces that allow for that person to easily move through environment. So these are specific correlations that we can look at, again, architectural decisions that can be made to help to healing and health promotion throughout. So again, this is the intent here was to really identify this as a journey, that healing is a journey and it's a moment in time, but it's not necessarily a destination, as Jennifer mentioned. And it's hard that it was pretty clear through this process that healing was not well or consistently used in the literature. So the hope is research really helps to bring alignment and better enhances the understanding of what a healing space is. And so further research could use this definition moving forward, as well as healing is not necessarily an endpoint and squishy topic, and it's, again, a journey and a process, an experience. As well as healing is highly dependent on the state of mind of that patient as well. So that is the conclusion of the work that we wanted to share with you today in high summary of the document, and I know that it's available online, and I will turn it back over to Alan.
Thank you very much. Before we get to the Q&A session, I'd like to say thank you again to the Herd Journal for providing free access to these articles we typically review. If you'd like to subscribe to the Herd Journal, go to www.herdjournal.com and use the code HERD20 to receive 20% off the annual subscription. The Center for Health Design is conducting a behavioral health workshop on September 27th in Baltimore. You can learn more about the faculty and agenda on the center's website under events. Be sure to mark your calendars for the next Evidence-Based Design Journal Club on September 13th. Our featured author will be Dr. Anjali Joseph, discussing her article, The Impact of Operating Room Layout on Circulating Nurses' Work Patterns and Flow Disruptions, a Behavioral Mapping Study. And now it is your turn to ask questions of the authors. Please feel free to type any questions you may have, and we will try to answer them. The first one that we have is from Rebecca Boyth, and it's, do you know what percentage of architectural firms engage with patients or utilize patient experience surveys in their design concepts? A little outside the scope of the study itself, but how does this relate to what you have seen out in the field?
I have no idea, but I'm going to hazard a guess that not enough. That's what I'm going to say. They should hire tech to do that, but or Advaya, right?
Right. Well, I was actually going to mention that in a lot of my research and patient experience surveys and looking at the correlation of the layout of a room to patient experience surveys, that a lot of the organizations and hospitals themselves aren't even looking at the surveys as a design opportunity. And so that there's a lot of times where we're seeing that they're completely different fields, and the patient experience officer actually is not necessarily fully engaging the architects in their solutions. It's more of an operational change or a maintenance improvement, but not necessarily fully engaged. So I would say that there's definitely opportunities to further integrate that. And yeah, so I'll leave it at that. We're actually working with ASHE and American Hospital Association to come up with some concepts to better guide the architects and the facility managers on how to use patient experience information to make physical changes. So look for something in the near future on that.
Very cool. I do look forward to seeing that. Mark Schweitzer says you seem to have selected some architectural interventions from Ulrich's paper and my own earlier with Samueli Institute. Are these the only ones you found valid?
No. So those are just the ones. So see, how would I explain this? So we started with trying to build on what we had gotten out of the paper that we did with Ulrich in 2008. And what we decided was that territory had been sufficiently covered at the time in terms of the very mechanistic, direct studies, say, Ulrich's study of views out the windows and stress or pain. So what we did is we wanted to look at different aspects of it, like I was showing in those conceptual maps. We did find, I think it was 34 articles, and those are cited in the paper. So there are other citations in there. We didn't find anything, though, that said design A or strategy X results in healing. So, which I don't know that we thought we would find exactly, but so it's harder. It's a little bit more difficult. So we tried to kind of replicate the table and show which aspects of the environment affect which aspects of healing. So that's what I would refer to in the big the mind map that we have.
Yeah, I really liked how you talked about the challenges of looking at healing as an outcome as compared to those more concrete ones that you were looking at in previous papers. And that kind of gets to Hank Hancock's question. Can you emphasize the distinction you're drawing between curing, which is easily measurable, arguably, and healing?
Sure. You want me to take that one, Larissa?
Sure.
I'll go first, and then you can add in. And now I don't remember, because we did, I think Larissa alluded that we had published this paper. It came out, I think, in 2016, and then it was re-released by Herd, so that's why it's not at the top of my memory. But there was some work done on curing versus healing, talking about kind of doing these case studies, and really you can be healed without being physically cured or getting rid of the disease, right? So talking about people who maybe are living long-term with HIV, but how they feel healed because they've come to terms with their disease, or maybe you have a manageable disease like diabetes. You haven't gotten rid of the diabetes, but you've learned how to manage it and live a life that you want to live, doing the activities that you want to do and having relationships that you want, versus, so you could see the trajectory of two different people being at the same physical state, but one being more at peace with and accepting their condition than somebody else, and that's really what I see as the heart of healing, is doing what you can, being self-actualized, and getting what you want out of life despite whatever physical limitations there may be on you. Do you have anything more to add?
Yeah, I would support that, and I think that was the impetus behind the military health system's support and interest in this, the healing component, and understanding how do you bring a person injured in the battlefield to a point of healing and support them in their healing journey, and recognize they may never be the way that they were at the beginning of, but then they are healed in their mental and social relationships, as Jennifer mentioned. So I do think that's different there.
That's fantastic. That's, I think, a really useful distinction. Given that it's so hard to study healing as compared to curative treatments or more concrete outcomes, why do you think it was important to try to study this as the outcome of interest?
Well, I think that it's really this is a lit review, right? And the whole intention behind this was to create a universal definition of healing space, because as we were finding in the review of the literature, nobody was universally defining healing the same. And so that I think that the intent is to create in order to study something and test something, you have to have a definition, and this definition has to be universally accepted and understood. And so that is really the intent behind this, is to recognize that the industry and and folks were banding around the word healing without necessarily having a grounded scientific definition for it. Jennifer, do you have anything to add? No?
No, not to that.
And on that sort of track, what led you to focus on coherence as a key component of that definition? I thought that was an interesting approach, and I have seen it in some other places, but I thought I'm not entirely sure that I've gotten my head wrapped around where that comes from.
I can't provide you a citation. I just know that it came out a lot in the literature, right? So we were looking for themes that came out in papers that we had read that were talking more about this sense of wholeness and acceptance. And so it's really kind of trying to pull the themes out from where people talk about healing and using their words to reconstruct what the pieces of it are.
So it's cohesion of the mind, body, and spirit.
Oh, sorry, I said coherence. Yes, cohesion. Yeah. Sorry about that.
So cohesion of the mind, body, and
the carefully crafted
all together.
Definition there.
Yeah.
I have a question from Kurt Chiosolo. I'm always interested in pursuing this kind of research and integration in architecture, but always run into challenges with funding and time. How was your research funded? Good practical question there.
Right. So the funding, as I mentioned, was from the U.S. Army Medical Research Team and Material Command under the IC4 program. And this was, again, the Samueli Institute was started and intended to really, over the course of the 15 years, study the science of healing. And so this funding was awarded to the Institute to more specifically identify these definitions and understand more fully the science behind healing.
Fantastic. Got a couple of questions from Kathleen Jones and Rebecca Voigt, both talking about how operational issues such as room preparation, discharge, cleaning, setup, and then the way that clinicians and staff interact with patients complement the healing environment as such, the physical component of the healing environment. Could you talk a little bit about how the work on the physical environment relates to those operational issues?
I would say the organizational, operational issues are, and it's probably heresy, but I would say they're probably more important, but that wasn't what we were looking at. But certainly that's the piece that I think has the biggest impact on an individual's healing is how they're treated, how the system is treated. So I think that's first and foremost what an organization should do to try to encourage healing. But obviously the built environment needs to support that. And the built environment, I think maybe the questions around like room discharge and prep for the room, a lot of that is what, you talk about how the space telegraphs the organization to people, right? So when someone comes in, if the room is dirty or looks dirty, that sends a message that, they weren't expecting me, they're not very well prepared for me, or they don't run a good organization. So, that wouldn't have anything to do with whether or not there actually is an infectious disease risk from the space, but whether or not you now have a sense of security that this organization is going to take care of things. And I think, another, like maybe on the positive side, right, if they've done things to make it look like they've thought about your experience, right? They've arranged the television where you can see it. They've provided a way for you to control the lights. Those things, again, tell you that, they're actually thinking about what my experience is in the bed, not just how can they heal me, but how can they make my experience more pleasant. And that was, I think, some of the questions around lighting as well. I've done a lot of research around sleep in patient rooms. and, and I've talked to nurses a lot, and they feel bad about going in the middle of the night to turn on the lights to do care, and they wish they could turn the lights on gradually. But for many of them, the environment is the limiting factor because it's not provided, because the controls to dim the lights were value engineered out at the last moment, or they weren't seen as valuable because that wasn't a critical part of healing. What we're doing, and on the converse side, some nurses actually have said, I feel bad about waking patients up and turning the lights on bright, but my job is to make sure that they're alive in the morning. And so that's my number one task. And if that means I have to give you an unpleasant experience and wake you up, then so be it, because you were alive when you woke up in the morning. You did wake up in the morning, so that was my goal. But I think, that's part of what we're advocating here is kind of expanding the concept of what a healthcare system does behind just getting you out alive, but getting you out feeling cared for.
Absolutely. There's a couple questions from Adrienne Berg related to where landscaping fits into all of this. I know you're looking more broadly than the sort of specific view out the window.
Question. Yeah, that's certainly a really interesting question, and there was research, some of the links that we found, views to nature, indoor plants, lighting. There's definitely evidence of all of those pieces. I don't feel like there's good evidence, though, to kind of pull those apart so that I don't think we can definitively say that, even saying, is it the light coming in from the window or the view out the window? I think that gets confounded a lot in studies. To some extent that's okay because we just want more windows with good views. If we can just have all of it, why do we need to pull it apart? So I would say yes, but I don't think we can say this is the piece that's most important. And, a view to landscaping is great, but probably if I had my druthers as a patient, let me go outside, which is not something commonly done. But so I think there's a lot of evidence that it works, but there's always more research to be done to show the impact of those distinct elements. But there's not always funding and time.
Especially when it isn't prioritized, and maybe this work will help to get that prioritized. Can you provide an example of how we can apply this work to our current hospital design work?
So I would say that, again, giving the framework that we've provided, that when you're doing hospital design and understanding how do you foster healing within that environment, you're looking at the three aspects. So it's the internal, the persons that are coming through, so it's the staff member or the patient, and then the facilitation of those relationships that you're trying to enhance, and then in the behavior, the choices that you're allowing to happen. So it goes even to healthy food options, and as well as those implementation of the healing behavior choices that are good for those, and then the external and the built environment component. So you're just being thoughtful in all different domains and not just trying to solve for one operational solution, but thinking all about the people and the process. And I think a lot of designers do that, but I think that this gives a little bit more of a structured rigor to kind of think through those pieces and pause and try to implement in a meaningful way.
And maybe just even using, it's not really a checklist, but kind of using those buckets of the constructs, psychological and social and functional, as kind of a checklist to look back at and say, what does my design do for this? Recognizing, just a way to remind yourself that people have these other needs. We're not just trying to lower their A1C level or get their blood pressure to a certain rate. We're also trying to help them on a path to healing. Or if that is the goal of your organization, then how is your design allowing for that and promoting it?
Yeah, that's a great point. Even very simple sort of structured brainstorming approaches like that seem to make a big difference in the ideas that people come up with. Melinda Saylor is asking about is there an optimal health system out there, a good example of how this works that you have seen?
This is from the operational and the standpoint. I would just say, I wasn't thinking about it this way, but we have just had the opportunity to work with Mayo Clinic, and they do a really good job of bringing everybody along to the same philosophy of care.
So there are lots of organizations that have been working on a healthy organization, as well as improving those health that organization. And so we've worked with many organizations that have done maybe a re-enculturation process where they've retrained the staff and recognized given the opportunity to the staff to help promote improve patient experience, whether there's a call light on, that somebody is able to stop in the room if it's just the need of a glass of water or a pillow, as well as improving the wellness and well-being of the staff and allowing them to take a break, to walk outside when stress levels get to a certain point. So I think that there are many examples of how organizations have brought these ideas into an organization and provided more of a healthy culture and training for that organization. I don't know if I've necessarily seen building environment with that. It's more of an operational training component. So, and I don't know if there's audio issues. Sounds like maybe so.
I am not clear on that. So okay. Another question that leads me to is, obviously we aren't there yet. This paper, as you pointed out, is a couple years old. What have you done since then? What are you doing now that perhaps relates to this that we should keep our eyes open for?
Jennifer, go ahead.
Okay, well, I'll throw out mine and take it off on a different tangent. So we're currently working on a project with Emory University on helping people with mild cognitive impairment. And so I've really kind of gone back to this work a bit because we've been thinking about how we can heal people, how we can restore or rehabilitate people with mild cognitive impairment. That often becomes Alzheimer's, not always. But so, how do we think about a disease process which tends to be one direction and a decline, and how do we think about improving those people's lives? So it's a really different, it's hard to conceive of things that way, right? Because we think, yes, well, all you can do is make them comfortable. But how can we actually start looking at these categories and thinking about, well, how can we actually improve their independence? We might not be able to change what's happening in their brain, but how can we change their experience of it? And one of the things we've been talking about is empowerment, which is, I think, a part of this, right? We're talking about having an empowerment program. So I've been thinking about with others in the group, how on earth do you empower people as they lose their cognitive function? What does that look like? And how does the built environment allow that? And a lot of it's, again, some of the work that we started looking at in this paper about the person-environment fit, and that maybe both of those pieces have to move a little bit. We can't just build an environment that makes everything easy, but how can the environment adjust to where you are? So that's some of the work that I'm involved in, and I'm just curious to hear people's thoughts about if anyone else has experience in that realm, or can we even do it? So somebody said here, losing cognitive function to what extent? So mild cognitive impairment can be the early stages of Alzheimer's. It can also not have a memory component, but just have an executive function component to it. And so what happens there is that people just have a harder time. Everything takes a little bit longer. You have a harder time functioning. You might be less able to remember things, harder time planning things out. So one of the tasks we're looking at is how to help people in their homes with preparing meals, with simple meal preparation. So how can they do that, those multiple step tasks? or how can you minimize the stimulus from the environment so that you have less disruption and that the environment helps people engage more easily or less frustrated by it, both in their homes or in, say, a day program that they're working in.
So I will also answer that how this has moved forward. So we were working with Lee Memorial Health System in Cape Coral that, again, was working on retraining their staff to encourage them and empower them to help the organization to be a healthy organization, healthy lifestyles, as well as encouraging increased patient experience using Lean as their rollout mechanism. So they actually brought together healing and the healing space and changing the healing space while also implementing a Lean transformation within the organization, which is a great intersection that you wouldn't necessarily think, but the implementation model was through a Lean understanding and operational excellence. The other component that I wanted to bring up is that another piece of research that we published in the Patient Experience Journal was a further exploration of where we actually interviewed patients in 3 different hospital settings to ask them what helped them in their environment, helped them to heal during their inpatient stay. And the findings of that research and study was really looking at the opportunity to make the environment more supportive for them to have relationships with their family members or loved ones in the room. So having a space to allow for them to bring their loved ones in, as well as things that reminded them of home. So these elements that we had in that room were the TV, as well as looking out the window and seeing something that's familiar to them. And so these, as well as watching TV or a care channel, which is a music program that has really beautiful nature scenes, and that was enhancing and supportive for them and helped them to heal in their journey while they were within the hospital. And so this, again, was bringing further this research of once we had a definition of healing space, we could talk with folks and have a better understanding of what was really helping them to heal. The one interesting finding from that study was that they were the noise of the room noisiness was something that would be a barrier to healing, but the conversations was they actually to hear the motion and the movement and things happening, that they felt that helped them to be cared for. So noise on that side was actually, they if it was too quiet, they thought maybe nobody was there taking care of them. So it's a different perspective. It was interesting findings from that study. And then to answer Rebecca's question in regards to rehab and long-term care facilities, yes, I'm currently working with rehabilitation hospital, Mary Freebed Hospital, and we're integrating the healing aspects and as well as health promotion for rehabilitation patients, and it's very much akin to that opportunity to really look at the opportunity to enhance the environment, to inspire folks to get back to life and daily living. And so using these domains and components from all 4 aspects and having that environment support them.
We're actually, I should mention, doing work with Ebola treatment centers and looking at seriously communicable disease units. So we have been looking at that from the standpoint of donning and doffing and how to keep the healthcare workers safe. But we are now embarking on a project looking at what that patient experience is. And what's really exciting is we hope to have the opportunity to actually interview the 4 Ebola patients who were treated here at Emory, because we're working with Emory on the project. But I think that's really, healthcare has done a really good job keeping them safe, keeping people from getting Ebola, and helping their bodies recover. But I think there's been a huge toll on the psyche of being in there. We heard one of the patients was in the hospital for over 40 days, and that's in isolation in a room. So, really kind of helping the healthcare workers think about what they can do to address the whole person, and not just the viral loads, but how to help them stay physically active and engaged when no one else can go in that room except the RN. That's the only person they ever see and touch.
That's fantastic. I really look forward to seeing that. Emily Gaines has added a question. Measuring outcomes can lend itself more to quantitative research. Do you think since healing is less easy to measure quantitatively, that it would lean more toward qualitative research? How could you implement a mixed methods approach in research that looks at healing instead of outcomes?
I agree. But Larissa's going to design this.
So that was the phenomenological study that I shared in regards. It was a mixed methods approach. So we had a survey as part of that, but then it was a interview and theming from those interviews. So that was probably the best approach that we could, where you're gaining insights and then cataloging and structuring themes from those discussions. So.
Fantastic. Just the mention of the word lean there, which is totally in a different context, reminded me of you mentioning that you're rolling out some of these ideas with lean, which does seem kind of counterintuitive to the way you often hear lean talked about, at the very least. I mean, I know for the true lean gurus, it's more of a culture change thing than about the specific tools and waste. But the way most of us see it in the real world, day-to-day practice, it's about cutting waste out of systems. How did you work on the messaging such that you ensured that healing as a process and healing as an outcome weren't classified as sort of avoidable waste that should be cut?
Right, and so that was Scott, the president of Cape Coral at the time, was very much in tune with making sure that this was a optimal healing environment-led process. And so it was the intent behind the whole process was to heal the organization and get back to the reason why we're all in healthcare, to help people to get better and to help people heal. And we all intuitively know what is probably the right thing to be doing. And so that is the first and primary thing. And then lean, yes, you can be more efficient, but it's always at the core of being present and relational with the patient and the caregiver and the staff member to provide their best health and their best opportunity for health. So some of those initial initiatives that they built in were walkways and pathways throughout the campus to allow people to have breaks and allow those breaks to happen. So a lot of times what we see in practice is that you have these beautiful gardens or outside dining areas that never get used by staff because they're sitting at their desk documenting in between their 2 seconds that they have to do that. And so what can you do to provide those breaks in the day? Or even they moved into the internal core of the hospital because they weren't able to take those breaks, to say, okay, you might not be able to do that, but we're still going to provide you a really great natural environment to make this occur within, the close proximity to your daily work environment. So again, meeting to them where they were and allowing them to be inspired to really make the right choice for a best work environment for everybody.
That's fantastic. So often we have all these great tools and techniques and approaches, and they end up butting heads and scattering our efforts in lots of different directions. I think it's really important to start from that healing environment as the key central theme and work outward from there. Mm-hmm. It looks like we have
It's fascinating that their lean process, their lean dashboard everyone had a healing outcome. So they actually quantified that. So
that's brilliant. Yeah. Well, it looks like we've come to the end of our questions and nearly to the end of our time. So we'll go ahead and say thank you again very much to Jennifer and Larissa for this interesting and thoughtful review of healthcare space, how healthcare space can foster healing. We have one more question, probably time for it. I believe we can make a big difference educating caretakers and patients with memory loss. I've been studying this for 20 years and incorporate it in my design work. One way for caretakers is to respect the patient because when they go in and ask them if they're ready for lunch or the medication, et cetera, and the patient blatantly refuses, the caretaker never takes answers to this question personally, but goes back and asks again in 20 minutes, and so on. It gives them dignity and power. Okay, so a great comment on how to treat patients with dignity and a slightly more difficult patient population with compassion.
What they say, that's a good idea. Yeah.
Exactly, as if they're actual human beings, you know?
Yeah.
Thank you. So thanks so much again for delivering this really excellent talk on a fascinating, especially to a nerd like me, paper. We're really very thankful that you were able to make this happen for us. And this concludes our event. We'll leave the webinar open for another 30 minutes so that you folks can download the EDAC and AIA CEU forms. Thank you again for joining us, and have a great day.